Good evening, everyone, and welcome to our Family Medicine Residency Showcase tonight. We're going to be hearing from Dr. Joya and Dr. Irwin at the Forbes Family Medicine program about dermatology. My name is Scott Allen. I am the CEO for the Family Medicine Education Consortium. And before we dive into our talk tonight, I want to just give a little bit of background about the FMEC. So for those who do not know us, we call ourselves a catalyst, a convener, and an incubator. And I really like to think of our goals as threefold. We try and encourage medical students to learn more about family medicine and consider family medicine for their career. We like to support family medicine residents who are in training, both to do scholarly work during their training, but also to think about their career options as they leave training. And we like to support the family medicine program directors and faculty across our region to also do presentations, to meet and learn with each other, to meet ACGME guidelines and other support. We are in 14 states and the District of Columbia. In the Northeast US. In those states, there's about 60 medical school departments of family medicine and 220 or so family medicine residency programs. We do an annual meeting each fall. It's about 2 weeks from now in Philadelphia. So hopefully some of you are attending, or if not this year, you will attend next year in Cleveland in September. And that annual meeting includes a residency fair. This year we'll have 102 programs at the residency fair. We also do an awards program. We have some learning collaboratives around different topics in family medicine and teaching and academic medicine, and other ways you can volunteer to be active with us. So with that, there's the dates of our Philadelphia meeting, and I'm going to stop sharing my screen and turn it over to Dr. Joya.
Thank you so much, Scott. Good evening, everyone. Thanks for joining us. It looks like we may have a small group, and we assume that people will trickle in, but our goal, I don't know what the weather's like where everyone else is, but it's gorgeous in Pittsburgh, and that doesn't happen often. So we may try to finish earlier so we can get a walk and, spend time with our families. But I would like to spend a few minutes. I'm going to share my screen. I'm going to be presenting today with Dr. Irwin, one of my co-faculty and friends. And we're going to be talking about dermatology in primary care. So here's a fun picture of Dr. Irwin and I and Stacy Nikoloff. Dr. Nikoloff is our program director from our annual faculty and resident retreat. So we'll do a little bit of talking about our program and a lot of talking about dermatology. But one of the opportunities here is to kind of showcase who we are and what we do. We go every year to Kansas City to the AAFP conference, the American Academy of Family Physicians, and we're always represented at the FMEC conferences. So about half of our faculty and a number of our residents will be in attendance in a couple of weeks, and we always enjoy the conference and highly recommend it. This is a photo of a group from retreat in the fall. It happens every year. We have teams and themes. So I was team Barbie here in the middle, and Dr. Irwin, I think, was team, what is that? Incredibles?
You're the Incredibles, yeah.
Incredibles. So it's really fun. We have a lot of fun. We do a tiny bit of business. We go away about, an hour or 2 hours outside of Pittsburgh, where our residency program is located. And we spend time together, which is really important for, building rapport with one another and building trust and just understanding that it's a lot of work, but it's also a lot of play. So this is one of our theme-based activities. Just a little bit more about our program. We are located right outside of Pittsburgh, Pennsylvania. So we're considered sort of mid-Atlantic / East Coast. We are an 888 program, so we have 24 residents, and we are an unopposed family medicine program. So meaning we are the go-to at our hospital, and we are located essentially on the hospital campus. We are a primary trauma center, have a CT ICU, a medical ICU, labor and delivery, a tiny bit of pediatrics at our hospital, and basically doing sort of comprehensive tertiary care at the hospital. At the clinic, we are doing comprehensive family medicine, including all the primary medicine, as well as gynecologic procedures, skin procedures, sports medicine, injections. So you name it, we're trying to do it. We have some specialty tracks with sports medicine, women's health, and starting a global health curriculum this year, as well as a lifestyle medicine curriculum that we started a couple of years ago with a lot of community projects and things going on within our larger network, which is Allegheny Health Network. And then our smaller program, which is Forbes Family Medicine. So it's a really exciting place to live, and Pittsburgh's, or to be associated with, and Pittsburgh's a great place to live. So talking about derm, so like any good lecture, we've got to start with an anatomy review. So this may be rudimentary, but I always like to go back to the basics, because when we're talking about definitions, nomenclature, disease processes, one of the things that we stress to our residents is if someone comes in with a wound or a rash or some sort of skin finding, at least a few precepts with Dr. Irwin or I, we're going to say, okay, then before you show me the picture on Epic or on Haiku, describe the lesion. Tell me what's going on and give me some historical data, because obviously your history of present illness can be really helpful in helping you to critically understand what's going on. So to understand the nomenclature and the definitions and the descriptions, it's good to understand or remember the anatomy. So when we're talking about skin, the bulk of the conversation happens with the epidermis, which is the outer layer, and the dermis, which is the deeper skin layer. And that's the layer where you get hair follicles, sweat glands, sebaceous glands, et cetera. And then this tiny little epithelium layer is sort of the coating for everything. So when you're talking about lesions and depth and invasion, a lot of what we're talking about is, do we think it's invading into the dermis, or is it just somewhat superficial and just having to do with the epidermis? So I know there's not a ton of participants, but we're hoping for this to be interactive. So if you feel comfortable, unmute yourself. And if I don't hear from anyone in a couple seconds, we'll go on. But talk about definitions. Can anyone describe a macule? Macule is
flat lesion.
I'm sorry, can you say that a little louder, please?
It's usually like a flat lesion.
A flat lesion, absolutely. Yep, flat. Any idea about size? Take a guess. There we go. So when we're talking about derm, we're talking about raised, flat, and then usually size when you're talking about primary lesions. So that, use that as a guide, and there you're going to see some trends. So good to kind of keep in mind. So yeah, absolutely. A macule is a flat alteration with a deviation of skin color. It could be accelerated skin color, or it could be decentuated, like a hypopigmentation. And it's usually small, so less than a centimeter. So then what's a patch? Anyone have any ideas about a patch?
It's greater than 1 centimeter.
Absolutely. You're catching on already. Yeah. So a patch is a big macule. So, when we're talking about, large birthmarks that are flat pigmented lesions, those are often patches. But yeah, the size is the differentiator. What about a papule? Flat or raised?
A raised lesion.
Absolutely. Any idea on size?
Less than 2 cm.
Close. So I'm following the definition of less than 1, which is good for my simple brain, because we're dealing with greater than or equal to 1 centimeter. So the papule is a raised lesion, usually less than 1 centimeter. So a small raised lesion. All right. So what about a nodule?
Raised lesion greater than 1 centimeter.
Absolutely. And this one's tricky because sometimes nodules can have depth that's more subcutaneous. So when we're describing nodules, often you're thinking about a breast nodule. And they can have depth that's palpable. So it could be more than 1 centimeter, but it may not be raised a whole centimeter above the level of the skin, to the naked eye. You would have to palpate it to understand that depth. But definitely primary lesion descriptors. So we're talking about a plaque. I'll just move on. So this is a raised lesion, usually a smooth surface, but not always. And again, this is a larger lesion when you're talking about a plaque, usually greater than 1 centimeter. It could be a confluence of multiple small papules that kind of coalesce together to form a patch. And it looks like one singular unit. All right, so can anyone shout it out? Just tell me where the pictures are and what they are. This one over here. This greatest lesion is 0.5 centimeters.
Papule.
Absolutely, a papule. It's a small raised lesion. What about these lesions? We'll say most of them are greater than a centimeter. Anyone?
Plaque.
A
Plaque.
plaque. Yeah, yeah, plaque. There's a lot going on in this person's back, some hyperpigmentation, some scarring, but yeah, probably a lot of plaque. What about here? This is 2.8.
Patch.
Yeah,
A patch.
absolutely a patch. So flat, pigmented, larger than 1 centimeter. And what about this one? Raised greater than 1 cm.
Cool.
A nodule. And again, that one may be deeper too. What about all these tiny little hyperpigmented lesions?
Macule.
Oh yeah, macule.
Macular rash.
Macule, yeah. And it's hard because you might be thinking, oh, I want to say melasma, or I want to say freckles, or, it's the colloquial terms. But, when we're talking about derm descriptors, these are all tiny little macules, like discrete lesions that are flat, that are colored, right? And they're definitely less than 1 cm. So think about your descriptors, and at least if you're precepting with Dr. Irwin or I. So more definitions. So what about a wheal? What's a wheal? And don't be afraid to be wrong. We like folks who interact and try. I have to remind myself about the less than 1 centimeter or greater than 1 centimeter thing too.
Wheal is a raised flat lesion that is greater than 1 cm.
Okay. All right. And close. What do you usually see associated? What's a symptom you usually see with a wheal?
Wheal and flare, like hypersensitivity reaction.
Sure. So do those hurt? Do those sting? Do those itch?
It is pruritic.
Pruritic, yeah. So typically itchy. So usually a raised area, and it's usually in reaction to something, usually allergically mediated. So we're seeing that edema, we're seeing that skin response to something, either contact or systemic, that's going on, usually very pruritic, right? So you can see other raised lesions that this could be a differentiator. If wheals, which are also kind of known as urticaria or hives. All of those terms are kind of used synonymously, all representing the same sort of process going on from a dermatologic standpoint. What about a vesicle?
It's fluid filled, is what we would say.
Yeah, a fluid filled. And is it flat or raised?
Definitely right.
Definitely raised. Yep. And this one is less than 0.5 centimeter. So often these are smaller, right, as your differentiator. As opposed to bullae or bullae, also fluid filled, greater than 0.5. So when you're thinking about these terms, thinking about diseases and illnesses that may have representative skin findings like 10, SJS, bullous pemphigoid, etc. What's a pustule? Flat or raised?
Raised.
Raised.
Contains pus.
Yes. So fluid-filled lesion, usually with purulent exudate. So fluid-filled, but the fluid is usually thicker, purulent, infectious in etiology, or inflammatory if we're talking about something like acne. But these are different examples of hives or urticaria or wheals. Again, all potentially could be terms that can be used synonymously. So raised, pruritic, some are more significant than others. You can have a singular one or two hive or wheals, and they're all collectively in response to something allergic that's going on. But you can see it's nice to think about the different presentations of skin findings in lighter skinned individuals versus darker. You may not really appreciate that erythematous nature in this darker skinned individual, but you can definitely appreciate the skin is inflamed, it's edematous, you kind of get like dilation of the pores, and it looks angry, right? And then the patient's going to tell you, I'm itching like crazy. Anyone want to name these lesions? Upper left. What do we got going on here?
Pustule?
Pustules, yep. What about here?
Vesicle.
Vesicles, yeah. I can hear the wheels turning what we think is going on with these without even hearing a history, right? What about these here?
I still want to say a vesicle. It looks smaller than 0.5 centimeters just because I have the really big one next to it.
Exactly. Yeah, it's hard when you're like, what am I looking at relative?
Yeah.
But yeah, these do look pretty tiny and there's multiple vesicles. I would agree with that. And then as opposed to this, it's look a little bit more profound. So these are probably bullae that have erupted, some of them, and then ones that are still active fluid-filled bullae. Perfect. Excellent. So going on with definition. So flat or raised size, that's kind of like where you start. And then you think about secondary lesions. So these can be on top of those primary lesions. So you can have a vesicle with an associated crust. So crust is an accumulation of exudate or blood. So fluid that has leaked from a primary lesion and is accumulated. An erosion is a shallow depression of the epidermis. I like to think of erosions like abrasions. So you get damage to that superficial layer of the skin, but these aren't going to be deep. These aren't going to leave a scar. When you think about scar formation, you have to penetrate into that dermal layer or deeper. So dermis, fat, into that subcutaneous space, versus if you just have a superficial scratch or abrasion or erosion, a break in the skin, that usually results in a lesion that's going to heal quite well, typically without any scar formation. An ulcer, on the other hand, usually penetrates into the dermis and usually heals with some sort of scarring. Atrophy is depression of the skin, and sometimes that's really hard to sort of see on a photo. However, you can often palpate atrophy because it can be difficult to determine without a history, particularly. But excuse me, that typically occurs over time due to repetitive trauma, where you get actually thinning or atrophy of the epidermis or the dermis if it's more significant and longstanding. And then fissuring is where you get epidermal, so that top layer that starts to have cleavage, it starts to split, and it's usually in skin and in areas that's very thickened or hyperkeratotic is a word that we use. And this occurs spontaneously, not usually due to some sort of trauma on the skin. So thinking about those secondary lesion descriptors, can anyone say what this, can you describe what's going on with this?
A crust.
Crust. So that's our honey crust lesions right around the mucous membranes. And what about this?
Erosion? I'm not sure though.
This one's a fissure.
Oh,
Fissure.
Fissuring usually happens in skin that's very thickened, hyperkeratotic, and it happens spontaneous. So the most common place you're going to see fissuring is in the feet, the heels particularly, sometimes in the hands. So that kind of very thickened skin.
So it's like more linear and deep.
Exactly. Yeah, and often asymptomatic. You know, these are those folks that you're doing your diabetic foot exams on and you happen to note. However, they can be if this is a poorly controlled diabetic, this could be an avenue for infection because it is technically a break in the skin, and that's where we talk about foot care and wound care and, debridement of callus formation so that we're minimizing the risk for infection for those who may be at risk. This lesion down here, any thoughts? Or we'll say compared to this one. And it's kind of hard to tell. But if I tell you this penetrates down to the fat layer,
Erosion, then ulcer.
absolutely. So this is pretty superficial. This is gonna heal. I think my kid, I got toddlers, so I think of brush burns, their knees. There's constantly abrasions on their knees, right? Abrasions or erosions is the dermatologic term, versus an ulcer is more significant, right? So your decubitus sacral ulcers are common, your diabetic non-healing wounds, sometimes more significant mucosal ulcerations. Think about that as your description for ulcers. I'm sorry, did you have a question? Anyone have a question? Yeah. And an atrophy. So when we're seeing this thinning, and this is one that you may feel, you'll feel the skin feels thinner. It feels softer in some ways compared to the surrounding skin that's more taut. And this is scar formation. This is atrophy of the skin down here. So going on, a few more secondary lesion descriptors. So we're talking about our scale. So this is something that is on a primary lesion or maybe on a primary lesion where you get alteration of the top layer, the epidermal layer of that skin. And we often describe scale based on how dense it is and also the coloring, so you can describe scale. I think the most common kind of way we think about scale is like psoriatic lesions that have kind of diffuse silvery white scale on those plaques, which is the primary lesion with scale overriding. But there are other lesions that you could describe that have scale. So white or brown, you can get sort of thickened outer skin, silvery or loose, again, talking about density and color, or seborrheic. So with seborrheic dermatitis or cradle cap, that's that condition where, or you can see it not just in babies, but in adults as well, where you get that kind of chronic yellow, greasy scale that is kind of loose and easy to remove, but is adherent to some extent on the epidermal layer of the skin. When we're looking at scar, we talked a little bit about atrophy and scar, but this is invasion into that dermal lesion or into the dermal layer. So you have penetrated through epidermis. And these are some examples of, I don't know where my first one, there it is. So upper left here, anyone have any thoughts on a descriptor of what that might be? That one's a little harder. Or if you were to describe the scale.
Fishnet-like scale?
That would be helpful. Yeah, I mean, diffuse, adherent, light brown, if we're doing the color, you can see that this isn't just one patch or one area, right? As opposed to these lesions, they're discretely covered in scale, and then you have skin that's not affected. This is kind of diffuse. So this is lichenified. This has been going on. This is chronic. This is something you'd see in like a lichen planus or some other disorder where you have chronic hyperkeratosis or thickening. This is called lichenification, but the description of what's going on dermatologically is this is a brown adherent scale, right? As opposed to these, which look more psoriatic in nature, you've got that classic silvery white scale over plaque, right? So the lesions are greater than 1 centimeter, they're raised, they're confluent, and they're covered in this scale. Here's that scale with a baby with pretty bad cradle cap, and it can invade, into the eyebrows and kind of that T-zone as well with that yellow sort of crusty adherent scale for seborrhea. And over here, this looks like atrophy of the skin with some hypopigmentation. This is probably scar formation. So I'm not sure the disease process going on here, but showing atrophy and thinning of the skin as opposed to these processes where you're actually seeing thickening. So a couple other things, and just shout out what you think you're seeing here, and it may not be something that we covered. What do we?
Bottom left is a keloid.
Yeah.
Okay, keloid, yeah.
Yep. Yeah. So it's kind of a hypertrophic, accelerated or exaggerated scar formation. And it looks like a little nevi here, probably. What about this one? Anyone describe this lesion?
It's a singular scale. I would say kind of like looks like a, oh, it's 2.8 centimeters.
What's the primary lesion?
The primary lesion, would it be a plaque?
Mm-hmm. Yeah, a patch or a plaque. That one's kind of hard because we can't really see how raised it is. We know that it's not a macule and it looks slightly raised. And I agree with you, it is
Yeah.
covered in like a whitish scale. So
Mhm.
yeah, probably a patch versus a plaque. That one
Okay.
a little hard because we don't have it relative to anything else. But yeah, absolutely. What about this poor kiddo here in the middle? What's going on with him? We haven't talked about it yet. Or her. What if I tell you that those are multiple papules on his lower extremities?
Oh, they're all raised.
Yep. We'll say most of them.
Mm.
Some are flat. And
Like
what if I tell you
purpura?
what's that?
They're like purpura.
Yeah, so we've got palpable purpura, probably some petechiae. So petechiae are the smaller vasculitic lesions. I mean, we don't have the clinical context, but we see those wheels turning. So again, when you come to describe your rash, we want to know what it looks like and then the history surrounding, so this is a toddler that has had viral symptoms for a few days and is now having GI symptoms, whatever. That's going to help us to determine our clinical. We're also going to look at it. We're going to feel it. We're going to see if it blanches. Those are all things that are helping us with our clinical evaluations. But yeah, so these are mostly raised. This is your classic palpable purpura, and you can think about what the diagnosis. These are probably
hypopigmented patch.
Yeah, I agree. Those are patches. Those look larger than a centimeter. So, and yes, they are absolutely hypopigmented. And then down here, there's probably a couple things going on here. Looks like right here, as opposed to hypopigmented, what is this?
Hyperpigmented.
Hyperpigmented.
Yeah, so darkening of the skin, probably chronic, because if you look at the surrounding skin, it looks like, again, we don't have the clinical history or the context, but it looks like skin that's probably thickened. Hyperkeratotic is the word that we use. Lichenified is another descriptor for thickened, chronically sort of damaged skin. And often you see this in lichen planus, where you have chronic scratching. So it's chronic trauma to the skin because of some underlying chronic dermatologic condition. So a few more, we'll run through these and then we're going to do a couple of cases because that's the fun stuff. Thinking about lesions as being discrete, so one or two that are sort of isolated versus confluent or clustered together, can be helpful in describing dermatologic conditions. Are they annular or round? Often oval shape will be lumped together in annular. Linear or in a line, or serpiginous, so thinking about the wheels are turning, what sort of dermatologic processes may follow these patterns. A xanthum is a skin eruption that is occurring secondary to some other disease process. So when we think about, you often hear a viral xanthum. So you may get a macular papular rash secondary to acute viral infection, COVID infection. And so that's a secondary eruption from a primary virus. It doesn't have to be viral, but often we talk about viral xanthoms because there's some classic ones. And then less commonly used is an ananthum. This is basically a mucosal lesion. So in my training and practice, I use the word mucositis typically. So when you see dermatologic invasion of mucous membranes, often you will hear mucositis, and it tends to be painful for the most part. But those are those eruptive lesions that happen somewhere in the mouth, vagina, anus, nose, so anywhere there's mucous membranes. All right. So, anyone want to read the case?
Yes.
All right, go for it. Thank you.
You are rounding in the hospital on a newborn. The baby was born at 40 weeks gestation via non-spontaneous vaginal delivery, and there were no complications. Mom had no medical complications during pregnancy. Today, baby is 2 days old and mom has noticed a rash on the baby's face and chest.
All right, so 2-day-old, firm, normal weighted baby, 2 days after birth. Anyone want to take a stab at what might be going on here? And there was no mention of the child being ill, or there were no sort of perinatal complications that they told us about. Or peripartum, I guess I should say.
I'm thinking of like, so whenever it's the first 2 days, I remember that it's nothing we should be worried about, nothing infectious, nothing that's kind of concerning. So it's like either milia, I want to say, or there's another baby xanthan one. I wasn't the best in pediatrics, but
you're thinking along. I like how you're thinking. So you're differentiating. Is this something I should be concerned about, or is this something that may be a normal variant? And absolutely, it's the latter. So this has a terrible name, Erythema toxicum neonatorum. It is also incredibly common. Like, I don't know the statistics off the top of my head, but I want to say, like, anecdotally, at least 25% of babies. And it's usually before they leave the hospital. Most of these SVDs are leaving 2 days, and then your C-sections are about 3 days in most places. These are normal skin eruptions, and it can look nasty. There could be sort of little papules, there can be pustular, they can sort of be macular papular, they can have different, but they look like acne lesions, and they're on the face, the trunk, the upper, like the thighs, and they pretty much diffuse, and they change constantly. So they'll have one on their face this morning, and then the mother calls, and now that one's gone, and there's a new one. That's a very classic description of erythema toxicum. But despite having a terrible sounding name, it is very benign and self-limiting, and usually will go away with about a week. And that timeline is really helpful too. Also, like, not a baby that was born in a woman that had no prenatal care or was septic, because then your differential is very different. Even if the child looks well, you're just going to start thinking of more ominous things. So yeah, we talked about most of the time within a week it resolves. This one also can mimic baby acne. So the same distribution, the same sort of appearance, although the lesions don't change as quickly with baby acne. And usually baby acne starts about 2 weeks. It's 2 to 6 weeks with a peak at 4. So that timeline is really helpful. Also very benign and self-limiting. Milia tends to be those little white dots that you see, almost like little whiteheads, often on the baby's face. It's not usually anywhere else. Also totally benign and very, very common. I think whiteheads. Yep. Usually most prominent on the nose. All right. So case number 2. Nina, do you mind reading this one?
of course.
Thank you.
So case number 2, 6-month-old female is brought to the ER by her parents. For the past 2 days, she has had high fevers around 103 degrees Fahrenheit and has not been eating well. No other significant symptoms reported. This morning, she had a seizure. The fever has broken, but now you notice this rash all over her body, spreading from the face, neck, down.
All right. Does anyone want to take a stab at describing this rash? I'm going to tell you, if you feel it, it has kind of a bumpy appearance.
Well, do you want to try? Since I took your last one.
Don't feel like you need to. What if I told you it's a macular papular rash? Fairly diffuse, right? We know that it started on the face and worked its way down.
Yeah.
And it started with a high fever. Any thoughts about what might be going on? This is a 6-month-old? Yeah.
Measles?
It's a good thought. So thinking about where the child is and the immunization patterns of where they live, and we are seeing a resurgence of measles in some areas. So definitely a good thought. And it has a similar pattern of spreading. Although those kids tend to be sicker and have more viral symptoms prior to the rash eruption, Whereas this kid, I don't know, she's got a high fever, but they didn't say anything about runny nose or cough or just sort of super high fever. Couple of days, broke out in a big rash. I'm going to tell you this, if you do peds or you do family medicine, this is something you will see, and it can be any time of the year. So put it on your differential. So when someone calls the on-call and, oh my God, my baby has a super high fever, and you say, okay, let's see, wait it out. And then 2 days later or 3 days later, they break out in this full body rash. This is what you should be thinking of. It's a viral xanthan. Anyone want to take a stab?
Bella,
What was it?
rubella.
Very close. So roseola. So one of the like very common viral diseases that we see in babies. Roseola is even more common, and we see this in and we don't vaccinate for it either, right? So measles, mumps, rubella, if it's in an area that there's fairly good vaccination patterns, you should see less of measles, mumps, and rubella. But roseola, we do not vaccinate for, so you will see this. So think about this in your pediatric population. It's usually the infants. I would say infants are the most common. What does it say? Say peak 6 to 7, can happen at any time. Tricky thing is, this is a long incubation period. So all those kids in daycare that are being exposed, like, it's inevitable. We've all probably been exposed to roseola and have hopefully some immunity. And that is that classic super high fever. These are these kids with 103, 104. So again, that may have provoked a febrile seizure. And then you get the break in the fever and the rash that spreads from face down, usually maculopapular. It blanches. The viral xanthan rash is usually almost always blanching as well. About that. All right, case number 3. Hey, Cindy, do you mind reading this one?
Sure.
Thank you.
This is a 16-month-old boy who presents to your office in July. He attends daycare and is vaccinated. He's been fussy for the last few days and hasn't been eating well. Mom noticed these sores on his hands yesterday and a few spots around his mouth today. No fever or other respiratory symptoms reported.
All right, here's your kiddo. So what are we seeing? Maybe some vesicles. We see an ananthum or some mucositis, so some mucous membrane involvement. This is a hand, so we're seeing some papules, some vesicles, definitely some inflammation on the feet. There's some more photos because this can look different presentation. Anyone have any thoughts? Toddler in July, daycare, also super common kid rash.
Molluscum or no? That's not really common.
Molluscum is very common. Does not usually involve the mouth. It can be perioral, but not usually inside the mouth. And that's not usually so abrupt usually. It's usually more insidious, and you start with a couple of lesions. These also some of these look kind of angry, right? Like, especially around the mouth. They look like they might hurt. I don't know if he's been fussy, right? So he can't really tell us. He's 16 months, but he's been fussy. He doesn't want to eat. So we can infer that they probably hurt, versus molluscum is often mostly asymptomatic. Sometimes they're a little bit itchy, but good thought. That's super common. Usually older kids though for molluscum. Also virally mediated. So this is hand, foot, and mouth with herp angina. So mucosal involvement, very common. No vaccine. So think about toddlers, daycare, eruptions, hand, foot, and mouth. It does not need to be all 3. Usually you get 2 of the 3. Adults can get this. It can be pretty severe in adults. Most kids will get it. And again, that there's those risk factors of like exposure of transmission by being in daycare with the age of they put everything in their mouth. So self-limiting, but definitely can hurt. So when we talk about supportive care, the most thing we worry about in the younger children is like dehydration and making sure that they're keeping up with mostly fluids.
Plus, he
Um,
was vaccinated, so I'm guessing that kind of rules out. So for okay, molluscum, if the kid was vaccinated, can they also get it?
Yes, absolutely. We don't have a infant vaccine for well, we don't have a vaccine for molluscum, period. It's a pox virus, so it's similar to HPV viruses and that are mediated, but it's to my knowledge, I do not believe the adolescent and adult HPV vaccine prevents against molluscum. Similar process, virally mediated pox virus, but again, even at that, we're not vaccinating until the earliest would be 9 if you're talking about HPV vaccine. So primary vaccination for infants, these are all fair game. We don't vaccinate, probably because they are so common. They're fairly benign. They're self-limiting. Don't ask a parent who's going through it if it's benign or not. But you know, these aren't going to kill kids, and these are things you're going to see in primary care and peds. And I promise we do more than peds. We just happen to start with some peds cases. But Dr. Irwin is going to go over a few more cases. I'm gonna pop off.
Okay. So I can read this next case. So you have a 1-year-old boy who presents with an itchy rash on his face, trunk, and extremities. He does not have any fever or any other systemic symptoms. So Maria, do you mind doing the next slide? So this is the rash. So how would you describe this? So you can see some papules here on the forehead, on the leg, on the chest. You can see some break in the skin, so you could probably guess that maybe he was itching it a little bit. This is a not as common presentation of this, but what would you think about with this one? If it's really itchy 1-year-old kid.
Chickenpox? Do you think of that one as fair? It's like a young, itchy kid.
Normally they'll present with like fever, other URI symptoms. This kid is not sick at all. Just comes in with an itchy rash. Maybe has a family history of it also.
No way.
So this is going to be atopic dermatitis, if you want to go to the next slide. So this is a chronic relapsing remitting inflammatory skin disease. 60% of patients develop this before age 1 and 90% develop it before age 5. It's very common. It affects in 1 in 10 people. Their thought is that there's like some immune dysregulation, mutations in the filaggrin gene, and it can begin in childhood. I've also seen this with adults who are older, like older 60s, 70s, start having eczematous rashes because their skin is so dry and they don't moisturize. So you can have it, you'll get it more commonly in like, the flexural surfaces is what we think about. I think if you go to the next slide, it talks more about where you get it. So kids, you're going to have, it changes as you age. So in kids, you're going to have more on the face, the scalp, the trunk. Children, you think about those flexural surfaces. And then adults, it becomes more on the extremities. And so it becomes this like vicious cycle of it's itchy, they scratch it, it gets inflamed, and then it can get that scarring or it's very bothersome for both the parents and kids, especially. So those are your symptoms. And then if you go to the next slide, you can get, sorry, Dr. Joya, do you mind switching? Sorry, you can get some pityriasis alba, which is another presentation of eczema, and you get more of a hypopigmentation. So you'll see these hypopigmented spots more in skin of color as is where you see this. And then if you go to the next slide, you can also see dyshydrotic eczema. And I wanted to point this one out because this presents differently than the other forms of eczema. You're going to get very popular, you can get vesicles or even sometimes pustules, but mostly like vesicles and papules on the surface of like the fingers. You might see it on the hand. This is intensely pruritic, and management usually includes like using warm water to wash, and then moisturizing after you wash your hands. If somebody like is washing dishes, you want to tell them to wear gloves. This one, you're going to need a higher potency steroid to treat. So this is just a very intense form of eczema that people can come in with. Okay. So who would like to read the next case? Shall we go back to the beginning? Lawal, do you want to read this?
Yes, please. 13-year-old girl presents for a rash on her face. It does not itch and gets worse around menstruation.
So what do you see here?
Some papular rash on her forehead,
Mm-hmm.
multiple,
Mm-hmm.
and
And beyond just papules, what do you see here? If you see that white spot in the middle of the,
oh yeah, it's pustular
right. So you have papules and pustules on the
and
forehead.
pustules, yeah.
In a teenage girl, what would you think about?
Acne,
Acne, that's right. So acne is a chronic inflammatory disease. There's four main factors that cause acne. So you have increased sebum production, you have hyperkeratinization of the follicle, so you get thickening of the skin there. Then you get colonization of it with bacteria, and then that causes an inflammatory process. So you can get non-inflammatory lesions. So that's like your blackheads or your whiteheads, your closed comedones. And then once you get more inflammatory lesions, so that's your papules, pustules, nodules. And so when you're talking about acne, these descriptions of these lesions are really important in determining like the severity of your acne, and then also like that shows you what to do in terms of treatment. So if you have a few non-inflammatory comedones, that's going to be a different treatment than someone who has pustules and nodules more, and if they're more diffuse, then that's going to lead you down a different treatment pathway with acne. Okay, so Mina, do you want to read this case 6?
Of course. A 21-year-old male comes in for a rash. He has noticed multiple small bumps on his abdomen. They are not pruritic or red.
So how would you describe these lesions?
I would describe these as papules.
Right. And it's hard to tell, but in the middle of it, you can see a little divot down in the center. And what would you call that? How would you describe that then?
An induration?
So not necessarily induration. Induration, you think of like firmness. It's an umbilication.
Yes.
And so an umbilicated papule, that should be like a trigger in your brain for this disease. And what do you think about?
Molluscum.
Molluscum. So this is molluscum. And I wanted to say that we see it more in older kids, but it can go into adulthood too. And so this is infection caused by a pox virus. It's a benign lesion. They're small, firm, dome-shaped and smooth, and you get that central umbilication. And that umbilication is really going to help you figure out that this is molluscum. They're going to be well demarcated. They're flesh colored and pearly. You normally see it on the face, the neck, the trunk. And then it's usually asymptomatic. And it does tend to clear by itself, depending on like how disruptive people feel, like very self-conscious with it. Sometimes you can treat it. For the most part, it does clear by itself. So, Cindy, do you want to read case number 7?
Sure. So this is a 64-year-old woman, has noted multiple dark spots on her face. They were initially smaller, but some have grown. It does not itch or hurt.
Okay, so how would you describe these lesions? It's kind of hard to tell with this picture, but how would you describe them?
Hyperpigmented papules.
Yeah, it's hard to see. Yeah, there's definitely some papules there. There might be some plaques. It's hard to tell, like some of these bigger ones, if they're bigger than a centimeter. So definitely hyperpigmented. So what do you think about when you see this?
They're typically benign lesions.
Yes, they're benign.
Age.
I'm sorry, what was the last thing you said?
They typically appear with older age.
Yes.
I think they're like colloquially called like sunspots. I forgot the like medical name.
So sunspots are actually solar lentigines, so that's a different one. This is seborrheic keratoses. So thank you. So this is that waxy stuck-on lesion, also known as seborrheic wart. They can be pale or brown or black, and you can see them on the trunk or on the back, and they're common, as you said, as you get along to in middle age and older. They do have a genetic tendency also. You'll see it within family members. Completely benign. People do not like the look of them, so we do freeze them a lot. On the next slide, we have another variant of this. This is a dermatosis papulosa nigra. So I always think of Morgan Freeman, the actor, and he has multiple of them on his face. But you'll see very small, so more of a papular version of these SKs. So this is a variant of that. Okay, I can read case number 8 here. So a 72-year-old male is brought in by his wife because she noticed a bump on his nose. It does not itch or hurt. He has never had a spot like this before. So when you go, how would you describe this?
Vascular raised lesion. So I would say it's not a papule, it's larger than that, making it a nodule, maybe we could
Could be,
say.
yeah. It's hard to say if it's nodule a nodule or a plaque, but probably more of a nodule. Yeah, a
Yeah.
vascular nodule. Here on the nose itself, it looks more just like an ulceration, and then in the next picture over, it's more that nodular formation. So when you see this, what would you think of?
Basal cell carcinoma, just because of the vascular shape,
Yes.
vascular like nature.
Yes, so exactly. So this is a basal cell carcinoma. It's the most common type of skin cancer. It's slow growing, but it is locally invasive. And you're right, you describe it as it's a painlessly, it can be raised or it can be flat, like we saw in the picture. And you can see a shiny or that pearly description of it. We do see the telangiectasias, but it can present without it. And then it's commonly seen on like the sun exposed areas, right? So your face, your ears, your neck, upper back, that's where we tend to see them. And so just if you go to the next slide, we'll see the different skin cancers we think about. So basal cell, as we said, is that pearly waxy bump on or a flat brown lesion versus like a squamous cell carcinoma. You're going to see a firm red nodule or scaly patch. The other thing you want to think about is like ulcerations that don't heal. So like I had a patient today who had an ulceration on her face that she says it's been there for a month and it's not healing. So then you worry about skin cancer with those kinds of patients too. Squamous cell is more likely to spread than basal cell. Then obviously we think about melanoma as the most worrisome, right? It can, if it's diagnosed early, it's easy to treat, but if it's diagnosed later, then it can metastasize. And that's where we think about the ABCDs of your skin lesion when you're describing like is there any asymmetry, what are the borders like, are there any color changes, what's the size of it. So that's what you think about with melanoma. So a great way to distinguish between benign versus malignant lesions is to use dermoscopy, and that can be a helpful tool that we in primary care use. This is something I use regularly when I am assessing rashes. And so this is something we try and teach at Forbes Family Medicine, is how to use the dermatoscope and start just noticing features that could be benign versus malignant under the dermatoscope. And so these are just some pictures of what benign versus malignant lesions can look like under the dermatoscope. Again, when you're looking under the dermatoscope, you're also assessing what is the structure? Is it regular versus irregular? What's the coloration? Is it this homogeneous, or is there like variation in the color? And there's different ways to assess dermoscopy, and that's a whole lecture in itself, but these are what we look at under the dermatoscope. And so at Forbes Family Medicine, we do a lot of skin care. We do cryotherapy to help treat like SKs and the actinic keratoses. We do shave and punch biopsies. We do cyst removals. We do elliptical excisions for when we're more concerned about cancers and need it to be removed before we even refer them to derm if needed. We do toenail removals. We do dermoscopy. We do inpatient consults. So we work with dermatologists who will say, I've been consulted on this patient. Can you go see the patient? We do the biopsies, and then the pathology and assessment is done with the dermatologist. And then we do have an outpatient derm rotation, and then as well as within our own health clinic, we do all these procedures. So this is every year when we get to our dermatology block during our didactic schedule, we do a procedure clinic. And so for us, this will be coming up in December, where we have stations and you get to practice suturing, doing shave and punch biopsies, doing excisions. It's a lot of fun. The residents really enjoy it, and it's a good way to practice some of these skills before you, or even if you have done them on patients before, but just getting better at them. So this is always a lot of fun. And so these are pictures from that clinic. And these are currently our residents that we have. We're an 888 program, and we are a nice mix of DOs and MDs. So we just wanted to showcase our current residents that we have. And again, this is back in Kansas City. We had Kit and Kylie go this year, and they had a lot of fun and enjoyed representing our program out in Kansas City. And this is just, some of the stickers that they had. So family medicine is social justice, and family docs do rock. So we enjoy very much what we do at our program. And if you want to follow us we are on Instagram, and Dr. Joya, you can jump in too. You can scan there to follow along with us. Our residents post about different residents in the program, different activities we are doing. So you can see some of the stuff on Instagram. And I think that is it. Does anybody have any questions?
Thank you for joining us this evening and for participating. We really appreciate. We didn't want to have to lecture. We wanted to be interactive.
Yeah.
Dr. Goya and Dr. Iron, thank you so much for doing this presentation. This was actually very helpful as someone who's studying for all of their steps right now. I really appreciate it. My name is Mina. I'm from American University of the Caribbean. And I wanted to ask you guys, basically, is there a fellowship option for people to go into dermatology after family medicine? Because it seems like your program kind of provides a nice, holistic, well-rounded training. So do some of your residents end up specializing in dermatology or pursuing anything like that?
Now, the only fellowship I know of, there's like one maybe in Texas, and that's it. But normally our residents feel comfortable enough to do this in their clinics without needing to do fellowship. So I think toenail removals are maybe one thing people don't enjoy as much, so they don't do. But for the most part, everyone's very comfortable doing cryotherapy, biopsies, excisions.
Great. Thank you guys so much. I didn't know that as a family medicine doctor, there's so much you could do. So it's a very holistic training, it seems, at your program. Yeah, I'm definitely going to be applying. Excited to hear about it. Thank you.
And we're excited to have you apply. That'd be great.
That's why we love family medicine. I mean, it's never boring. You go from seeing a newborn to seeing your patient, you've seen the grandmother of the child, and then you do a derm procedure and then a gynae procedure and a sick visit. So we're never bored, right? We have to be the jack of all trades, and we want our residents to come out feeling comfortable. And I think the beauty of our program, I just will sell it for a minute, is that we have a really nice distribution of folks going into hospitalist medicine, outpatient only, academic, and then fellowship. So we always have at least one or two going into sports medicine with a strong musculoskeletal background. We have one going into palliative care fellowship this year. One of our residents is going to do a certification in cosmetic dermatology. So that is an option for, I think, any licensed physician could get a certification. That's not a fellowship, that's not a board certified role, but there are options, right? You have the basic skill set, and then you can sort of subspecialize and do a lot in family medicine.
And the residents really get to know the specialist really well. So like the dermatology specialist, they just text him and they're like, hey, I saw this rash. I don't know what it is. Can you tell me about it? And so that's always a nice resource too. And we do that with a bunch of our specialists.
In a secure way. We use
in a secure way. Yeah.
Photos and our EHR. So we're not putting faceless information. So, but we didn't put our information on here, but we're happy to add it to the chat. So if anyone has questions or wants to get a hold of us, please do. Otherwise, we're going to give you your evening back. But thank you for taking this time.
Yeah. I'll put my email in. Oh.
Okay.
Oh, nothing.
I don't know what I did.
What do you, Melissa?
Great.
Sorry, I lost my screen. I don't know what I did.
Can anyone?
Oh, here we go.
They're there. Yeah, and thank you very much. I just want to say thank you to our speakers, Dr. Joya and Dr. Irwin, and for a great talk. And I know it's a great program, so hopefully you learn a little bit more about that program as well. So, anything else, Dr. Joya or Dr. Irwin?
No, thank you for your time and the opportunity. We appreciate it.